this time and we'll see what happens. Hi, everybody. Welcome to the next episode of Admit It or Not. I'm Dr. Rebecca Griffith. I'm the EDPT, and I'm here today with Dr. Nechvatal. And I'm going to let you go ahead and introduce yourself.
Thanks for having me. My name is Sarah Nechvatal, and I am a PT practicing in Madison, Wisconsin. And I have been primarily acute care focused, but about 11 years ago, I started a PT in the ED practice at our hospital. And we function mostly as an on-call practice. And yeah, been doing that ever since, mostly acute care, but on-call to the ED ever since.
Awesome. So I think people have so many questions just about emergency department physical therapy in general, which we're trying to address, right? Like that's part of the point of all of these different podcasts. So one of the things that I like to ask people who actually started their program was, what barriers did you encounter while you were trying to do that? Because starting any program in a major health system is a huge undertaking.
Sure. Yeah, I mean, starting any consultation service in any setting, really you just have to identify the stakeholders. So, the management, the physical therapy management, they wanted to know how much FTE it was going to take up. They wanted to know the financial benefit for the hospital. They wanted to know, how much time it was going to take out of my day to address the issues in the ED. And then, of course, there are the ED staff, the physicians and the nurses. Surprisingly, I thought that the emergency providers were going to be the most resistant, but they were the most accepting and super excited to have another tool in their bucket to help their patients. So they were pretty easily convinced that it was a necessary service to provide their patients.
That's a win.
Yeah, for sure. It's a win. I felt like the nursing staff was surprisingly resistant to having PT. Yeah. And I found that in talking to them, that their biggest concern was, how long is this going to take? How long is it going to take for you to get down here? How long is it going to take for you to take care of the patient? Is this going to prolong our throughput? Because the emergency departments are judged on their throughput, meaning how quickly the patient leaves the emergency department after arriving, which was something I was not familiar with prior to starting that. So, I said, I'm not really sure how long it's going to take me to do that. So I'll track it. So I did. I said, let's make the expectation that it takes less than 20 minutes for me to get down there, and then hopefully less than an hour for me to assess and treat the patient. And we did track it, and our average time to arrive after we received the consult was, I think, 18 minutes, and our average assessment and treatment time was 45 minutes. So
that's amazing, especially in an on-call program.
Yeah. And so the nursing staff, after they realized how quickly we were arriving, which was much quicker than most of the other consultation services.
Right. I was going to ask, does anybody track how long it takes neurosurgery to get to the bedside?
Exactly. And so I think that they have been, resistant just because of experience with other programs. I think they were pleasantly surprised to find out that we were pretty quick to respond.
Awesome.
And then their patients were happy too when we were done.
Yeah. Did you find that there were things that you could do to help the nursing staff too?
Absolutely. Yeah. I mean, I think, every nurse and physician, they want their patients to feel better, and so when a patient comes to the emergency department with, let's say, severe back pain, most of them were using medications as their intervention because that's really all they had in their toolkit.
Right.
And so I think, although it's easy for them to do that, I think that they were happy to provide a different option for patients, especially for the many patients who come into the emergency department who perhaps may be med seeking or have a history of utilizing or abusing medications. So, no one feels good about giving somebody opioids if they would like to be able to avoid it. So I think the providers and the nurses were just happy to know that they were providing a holistic option for their patients that was non-pharmacological, and they were getting good results. So it's been, I think helpful just to make the patients happier.
That's great. I think too, there's an opportunity for us to help with like how nursing cares might be best undertaken, like best ways to help that patient roll, best ways to help that patient transfer, what assistive devices you might recommend that they use while they're there, what level of fall risk are they, that type of thing.
For sure. Yeah.
I've noticed too that often nursing staff wants to know, like, can this person get up and walk to the bathroom? Can they use the commode? Like every time we try to use the bedpan, they scream because they have so much pain. Like, what would you suggest? So I find that to be an opportunity for us to collaborate with the nursing staff as well.
Yeah. And I think too, since we've been involved in the ED, I think they have stopped providing crutch training to people over 65 unless they were like a marathoner or like a weekend warrior. So I think that has been helpful because, prior to our involvement, it was just kind of like crutches for everyone who can't walk on their own. And it wasn't their fault. They just didn't know any different. Or a standard walker, which also we all know is not the best option for most people. So I think just seeing different options, showing the nursing staff all our different equipment that we can use, I think has been really helpful for them as well.
I think another thing that I noticed a lot was sling placement was always a little bit of an issue at first because the slings would be either like way too small and half the arm was hanging out, or it would be on but not like secured, because when they tried to put it on the patient was in so much pain and they didn't know how to fit it, so they just put the arm in the sleeve but never like attached it. So I felt like that was another opportunity for training. So somebody was asking, I think on Twitter the other day, about that every patient that they would see patients who were like 85 would have 2 flights of stairs being given crutches and sent home, and then that patient would come back with a fall. So I think you point out a good reason that we're there, so we can help make sure that those patients aren't coming back, that they're leaving under the most safe conditions that they can. But also a huge opportunity to train the staff, right? Do you guys have any experience doing that in your program, or because you're just on call, do you do less of that?
We haven't done that much of it lately. I think in the very beginning we did more of it, and just lift training too, just using stair steady lifts, and proper use of Encore or Sarah Plus's like easy stand type lifts. And just I think that was helpful. Our physical therapists in our hospital do like the safety equipment training for all the nursing staff in the hospital anyway, but just especially for the emergency department staff, because I don't know if it's just the nature of the beast, but the cots or the emergency beds that we have they don't go very low, so they're essentially like leaping.
Those are the worst.
And you say a little prayer that they are still standing once they hit the floor. So it's usually using a lift is a safer option for somebody who's not extremely strong.
I wonder why that is. Like, can we just all agree that emergency department gurneys are probably the worst piece of medical equipment out there?
They are. I mean, I'm sure they're designed to save lives, which good. Yeah, that's important. But
that is important. But I also wonder, like, what percentage of people are in the emergency department to have their life saved? I mean, ideally, it would be a huge percentage, but it's so hard because you can't position patients. They're so narrow that they really don't fit people very well. You can't really roll on them. They're not like very, like, gosh, for me, it's when you lift them to try and get the head of the bed up.
Yeah.
Or if somebody goes to lower it and then it like jerks and slams the patient down and the railings are flimsy. I don't know. It's a whole thing. Maybe we need to start a new business on making new emergency department gurneys.
Yeah, let's go. High-low beds. You bet.
So anybody out there in the world listening that is involved in biomedical engineering, call us. We'll help you figure this out. We'll make, probably $200 and then we'll move on. But then they'll probably sell them for like $30,000 a piece, right?
Mm-hmm. Maybe we should patent it. All right. Maybe we need to edit this part out. Don't
so we can still have our brilliant sales idea.
For sure.
Well, this way we'll find out how many people are listening, right? Now, tell me, with your on-call program, the problem that I feel like people have when they have an on-call program is that what happens to your patients that you were supposed to be seeing upstairs? Because if you're in the middle of seeing a patient and you get this phone call, like you said, you have about 20 minutes to finish up what you're doing and then rush down. But then what about the patients you were supposed to see next?
Good question. So at the hospital that I've been working at for the last 11 years, we were basically seeing evaluations all day in-house. So we were seeing inpatients or observation patients in the hospital. And we were scheduled to see evals all day long. So if we were to get a phone call to the emergency department, then we would reschedule our next 1 or 2 evaluations to a different acute care physical therapist. So they were still getting seen. They were just probably seen later in the day. And then that gave us the room to go to the emergency department to see the patients down there. So it's just really flexible. I mean, really, acute care in general is a fluid schedule, always changing just because of the nature of the hospital setting. But
yeah,
it just makes it easier when you have evaluations scheduled versus treatments, which often patients are aware of the time that therapists are coming for treatment sessions. And then sometimes they're pre-medicated. So it's really not ideal to reschedule someone who is in treatment. So evaluations are a lot more flexible on that.
Now, what does the therapist who has to pick up those extra patients think?
I mean, that's just part of the deal. I mean, it's just like, it's just part of the team, you know, the rest of the team too. Something falls through or one of their sessions goes long and then they have to reschedule. It's just constant change. And that's just how it is. Yeah.
Well, that's good. And how many patients on average do you feel like you were seeing every day?
Emergency department of patients or total? Emergency department, I think we were averaging, well, I was averaging about like 2.5 a day in the ED. So then I was seeing 5 or 6 regular acute care or inpatient therapy, or excuse me, inpatient evals during the day. So 8 patients total. Our productivity expectation was the same as it was for the rest of the team. So we were seeing 8 evals a day total between
that's a lot
care and emergency department, which is a lot. Yeah.
That is a lot. Okay. And you feel like that worked pretty well?
Yeah.
And how many beds was your emergency department?
29 beds.
Okay. So not too bad. What were the primary complaints that you were seeing patients for?
Our most common, I think it was 45% of our diagnoses was back pain. And then we saw a lot of falls, gait instability, failure to thrive. You know, people, they were concerned about being able to go home and be safe. Yeah. And then we saw some upper extremity, lower extremity pain, vestibular. And I think we've had like a handful of like non-cardiac chest pain.
Okay.
Complaint.
I feel like it comes in waves, right? Sometimes you won't see those patients for weeks, like you won't see anybody with wrist pain for months, and then one day you'll have 3 or 4 in a row. It's kind of how that goes.
Yeah.
So tell me, what do you think? What would you tell somebody who's trying to decide whether they should have a full-time program or an on-call program?
You know, I think really, if you are working in a hospital system and you don't already have PT in your emergency department, you just have to start with something. And it's challenging logistically to just go full 1.0 FTE or have a residency down there. It's challenging. If you work for a healthcare system that is on board with that, like it can run with it. But most hospital systems are not okay with that. That being said, you just have to start somewhere. And really, most, I don't want to say all, but most healthcare systems and acute care programs are going to have space to add 1 or 2 at least a day without having to adjust an FTE. And so if you market one diagnosis to the emergency providers, like if you have therapists that if you think it's just going to be all the therapists are going to have to cover it, then most acute care therapists, I would hope, feel very comfortable seeing falls, gait instability, failure to thrive, because that's like our specialty in acute care, right?
Right.
So if you at the very least market that specific chief complaint, diagnosis, whatever you want to call it, to the emergency staff, they're going to call you to assess home safety for these people because they're there. In every hospital, there are patients coming to the ED for that specifically. So if you start with that, then go from there, because then you'll build a relationship with the emergency providers and the nursing staff. You'll then be able to say, hey, while I'm down here, I see there's somebody in room 6 and they have back pain. Do you want me to take a look? Because I promise you, no emergency provider went into emergency medicine to treat back pain. Not one. I haven't met one yet.
I think that's fair.
I think if you were to go down there, and if your acute care therapists are feeling comfortable seeing patients who have back pain, then I think you can easily get several consults for that specific chief complaint, because there's a lot of that in the emergency department.
I feel like those two things are like the biggest issues.
Yeah, for sure.
Probably back pain and falls and home safety, maybe vertigo number 3, depending on where you are. What are some traits that you think make an ideal EDPT? Because it's a whole different world, right? Like it's a whole different world. And I love it when you describe the unicorn of the ED. So tell me about that.
So, I mean, the most ideal PT for an emergency department would be the unicorn PT, who is somebody who is comfortable assessing and treating literally everything that PT could possibly assess and treat. So that person, as far as I know, doesn't exist. But I think whatever you are offering the emergency department is more than they had before, which is nothing.
Good point.
So, I mean, being able to do mobility assessments and home safety evaluations, obviously very important. Be able to do a musculoskeletal exam and treatment, very important. Vestibular assessment and treatment, very important. And then there's a lot of other things that some programs are doing, like wound care and casting and assisting with reductions of dislocations and fractures. And there's so much opportunity, and there's so many things that a lot of us aren't even doing yet that we could be. So, I think really what it comes down to is a personality trait more than anything, just being comfortable with the chaos and the unknown. I think that's kind of what draws me into it. When I was in undergrad, I was a student athletic trainer, and I really enjoyed the uncertainty of what was going to happen next, like that adrenaline. I really enjoyed that. But I think someone who perhaps enjoys that type of chaos and uncertainty, I think would be really well fit in the emergency department.
I love that. I think that that's absolutely right. I don't think if you thrive on predictability, consistency, and routine, this is not the place for you.
No.
And if you do your best work without pressure, not the place for you.
No.
But if you like things to be unpredictable, fast, stressful, like coming at you, I think it's definitely the place for you. If you are also a unicorn.
Rewarding.
Yes. I was talking to a physician about that, and like the delta of change you can make is huge.
Yeah.
And so when you see the patient and they're in excruciating pain and you make even a small impact, the delta is huge. Like the change wave is enormous, versus if you're seeing somebody in outpatient PT for weeks and weeks and weeks, but they already had mild pain to begin with. And so by the time you kind of make it to that end of the episode, they may be doing things a little bit better. Their pain might be a little bit less, but like, there's not that like big fireworks display of, yes, I made this huge difference. And now this person can walk out of here. Or like that moment when you get the Eppley maneuver, like just right. And the patient looks at you and they're like, is it voodoo? What kind of magic was that? Like, because they've already had medications, they might have had fluids, they've been trying to rest, and like nothing's been working. And you come in here and you spin them around a few times, and they're like, it's amazing. So I think that's it really is the best. So tell me a little bit about urgent cares, because I know you have some thoughts about whether a physical therapist should be part of that, and about access to physical therapy in general.
Yeah. So, there were so many therapists who came before us that fought so hard for direct access, which we are so appreciative of their work. But unfortunately, now that we all have direct access, we have this next problem that we don't have early access. So there's no point in having direct access if you don't have early access to PT. So that isn't any setting. That's outpatient PTs within 24 to 48 hours. That's emergency department PT. That's urgent care PT. Even having home health PTs being able to assess you in your home within 24 hours of discharge. So it's so important that PTs are where the patients need them.
Yes.
So if a patient has 10 out of 10 back pain, but they can function at home, then they should be able to go to an outpatient PT within a short period of time and have their needs met. If they have 10 out of 10 pain and they're not really functioning and they need to be seen right now, they should be able to go to an urgent care and have a PT there being, ready and able to assess them. And even though we don't think that emergency department is typically the area that someone should be getting their care if they have back pain, if someone has 10 out of 10 pain or 20 out of 10 pain, they will always self-select an emergency department if they're scared.
Yes.
And so,
as they should, right? That's the point.
100%. When
it's
I
an
have
emergency
10 pain, I will be at the emergency department, and I'm going to hope that there's a PT there, but that's where I'm going because I'm scared. Right?
Exactly.
So it's important that we're there wherever patients need us. And so in Wisconsin, we've started this early access PT coalition, which is basically a group of PTs who currently work in emergency or urgent care settings or outpatient settings. And we're trying so hard to make it the standard so that PTs are available in all of those settings across the state, so that patients can reach us when they need us. So we are making good progress. We're kind of on a mission to be the first state in the US to make this the standard. So like I have mentioned before, game on, race ya. I know Colorado is also trying hard. So yeah, we're working on it.
Well, and I think you and I have had this conversation before. Like if I wanted to see a chiropractor today, I could.
Yep.
I guarantee you. I mean, and not just because I'm in Colorado and there's a lot of chiropractors here, but like I feel like if I wanted to even just walk into a clinic somewhere, they would make it happen.
100%.
If I tried to walk into a PT clinic today, I suspect that would not be the case. And in our emergency department, we're working with our outpatient clinics to help kind of triage patients to who needs to be seen really soon versus who can be seen in a week or so, like whose symptoms are like not as irritable and are stable, or whose symptoms are highly irritable and unstable and need to be seen sooner. I mean, one patient comes to mind, somebody who had been to the emergency department, 3 different emergency departments for the same issue, and they hadn't been able to get in to see their primary care doctor. They were told 2 to 3 weeks, and they hadn't been able to get in to see a physical therapist because they were told 5 to 6 weeks. Yikes. And so without that like access to care, I mean, they just went to where the safety net is. So I think what you guys are doing in Wisconsin is amazing to try and make sure that patients have access. And I really liked what you said about what good is direct access without early access, or even I would say ease of access. Mm-hmm. I also think like what good is direct access and early access if patients don't know that we're the people who can help them. Because like you said, if patients are scared, they're going to go to the emergency department. They're not going to think, I should call a physical therapist and make sure this isn't something scary.
Right. Exactly.
So I think that's the next step too, right? Like we can get the legislation to allow direct access. We have the training to manage that. We now can put early access into place. But what do you see as like best ways to solve this right provider, right time, right message to the target patient?
It's a great question. That in our committee, our coalition, that's our final goal, which is years out, unfortunately. But it basically is so that once we do make it so that PT is accessible in all settings quickly, then it's how do you market to the community? How do you educate the community on basically how to be healthcare literate? And it's not just PT. How do you educate the patient on where to go for what symptom, and that is a challenge that is much greater than just PT. But I think 100%. In general, it's going to be multi-level. It's going to be commercial marketing. It's going to be marketing through primary care physicians. It's going to be education in schools potentially at some point. I mean, I think healthcare literacy starts so young. It should be starting elementary schools, frankly.
I think when we look at how things have gone during the pandemic, as far as people's understanding of science, literacy, people's ability to interpret research, people's understanding of, basic healthcare concepts has been very variable across the country, across the planet. And I also think the original intent, in my opinion, of a primary care physician was to be that person, that cruise director of health. So that, Sarah, if you didn't know where to go, your primary care doctor knows where you should go.
Right.
But the access to primary care physicians and the shortage of primary care physicians is not really allowing that to happen.
Right. And truthfully, primary care physicians also don't really know what we do. They know a lot of like the musculoskeletal stuff, but they don't know a lot of the other stuff that we offer.
Right.
And you could probably talk to a lot of primary care physicians and they would be shocked to know that we're in the emergency department.
Well, yes, my primary care physician knows because we have that conversation. My pediatrician knows. And so that has led to conversations of like, oh, we should have a physical therapist in our office that could, when somebody calls for like a musculoskeletal complaint, we could just put that person on your schedule instead of our schedule. So, I mean, there's concepts around that and like that team-based healthcare. And I wonder if that would get us a little bit more upstream to help really manage patients' health concerns. But I think it's difficult to also connect all those components. But I could see that in a pediatric setting, a physical therapist there to help screen for motor milestones as well would be really helpful. I'm not a pediatric therapist, so I'm sure there's about a million other things they could do in that setting. But I think that it's really interesting to see how we can communicate and how we can better position ourselves in the healthcare system. But I think a lot of changes are going to need to happen going forward.
Yeah, for sure. But we have to start with what we can control right now, which is being available and accessible.
Yes.
We have a lot of work as a group, as a profession, to make that happen before we try to market outside of our profession.
Agree.
I would say probably at least half of our PTs in our profession don't even know that PT in the urgent care and the emergency department is a thing. So
yeah,
we've got work.
Sorry, go ahead.
I was going to say that we just have a lot of ground to cover before we start marketing to the community, I think.
Recruiting help now. Anybody who wants to jump in. So my question for you is then, there's all this conversation about how there's so many PT programs and the class sizes are growing and there won't be enough jobs for all the physical therapists that we're creating. I personally have a lot of opinions about that, but I'm wondering what you would say to people who feel like we're going to have too many PTs.
I don't see that as a concern at all, frankly. I mean, I live in Madison, work in Madison, and we historically have a very saturated PT market. And I think that's partially because we have a PT school in town. Madison's kind of a smaller, big city. And then there's just a lot of PT schools in Wisconsin. And there is room for growth. I mean, we are scratching the surface on what we can do as a PT profession. And the pelvic health world is kind of blowing up. And I think that there are other specialty areas that are also expanding. I think that there's so much growth. I mean, obviously within the emergency urgent care settings as well. And, if it truly does take 2 to 6 weeks for someone to initiate care with a PT, we've got plenty of room.
Well, also, if the overall average utilization of a physical therapist is like 7 to 10%, then that also means we have 90% of the population that is not accessing PT,
right,
let alone all the places that I think PTs could practice that we aren't. So what I usually say to physical therapist students who are concerned about that is, your job might not even exist yet. The place where you'll practice and the work that you do as a physical therapist may not have even been created yet. But it's hard to think outside the box when all you can see is the box.
For sure.
But I think what you guys are doing in Wisconsin is really looking outside the box, blowing up the box, and inviting people into your space to allow people to access physical therapy. So congratulations for the work that you're doing. I really appreciate it.
Well, thanks.
You guys are going to be national trailblazers. And if you win the race, I'm happy to learn from you and get it going here in Colorado as well. Okay. Are you ready for the case?
Okay.
All right. So admit it or not, I'm ready for our case.
Okay. Let's hear it.
You tell me.
Oh, the case that I saw in the ED.
Yes,
okay. So
tell me.
There have been so many cases that I would love to tell you about, but so I can think of this one guy specifically who I think he was probably in his 60s. He was a frail gentleman. He had been homeless for several years. And as you can imagine, homeless in Madison, Wisconsin is not a very comfortable place to be outside in the winters. And it was winter time. No, sounds terrible. It gets very cold in Madison. So in the winter, this man was ice fishing. He was sitting on a bucket for several hours. Picture a white bucket upside down. He was sitting on that. Like, that sounds terribly uncomfortable. For several hours ice fishing, as we do in Wisconsin. And he came into the emergency department because he couldn't get off the bucket. Like, he could not stand up. His hip hurt so bad.
Oh no.
And I know. I mean, I can't imagine how uncomfortable that would have been. Anyway, so they did an x-ray and it was negative.
So did he call the paramedics to come get him?
I think he flagged somebody down to call the paramedics, I think. Yeah, because he didn't have a phone or anything. And so he was brought in by ambulance, and they did plain films and they were negative, and they called me down because he couldn't get out of bed. And, obviously they're like, okay, well, he doesn't have a mechanism of injury really, other than like prolonged sitting. It must be muscular. His plain films were negative. And so when I went to assess him and doing my special test, and then he wasn't presenting as if he had a fracture specifically, but his level of pain and just looking at some of the other history, he has not seen a primary care doctor in over 30 years.
Oh no.
Very frail, but he's also homeless, so he doesn't really have access to nutrition or shelter, so that kind of was consistent with his lifestyle. But his skin was really mottled around his leg, and just kind of in general just didn't really appear well. And so it was just one of those things where it's just like nothing was really adding up, and it just kind of gave you like that weird feeling.
The spidey sense.
It was the spidey sense.
The unicorn sense.
Yeah, perhaps.
The unicorn horn tingle. That's what we're going to call that.
Sparkle.
Yes.
So I did press on maybe doing some CT imaging just because it just didn't feel right. And he had an osteosarcoma, unfortunately. And it was just like that day that it just really ramped up, probably just because the position he was in.
And exacerbated by the cold. And
yeah, exactly. All the things. And so he was admitted, of course, and then was treated medically.
Admitted or not? Admitted.
Yeah, admitted.
Yes, definitely.
For sure. Unfortunately. But at the same time, if PT would not have been involved, what would have been the outcome? Would they have discharged him potentially, with a bunch of pain medications and good luck, like who knows? So, but because his plain films were negative, I doubt they would have done further imaging at that point.
Yeah. And so really, do you think because of your on-call program setup, do you think they would have called you if he could have stood up?
If he would have stood up, probably not.
So he would have just gone back out into the world with that undiagnosed.
Yep. So, but there's so many cases that are rewarding, and like in a good way, where, like you said, you can do a great Epley maneuver and they have instant relief of their symptoms, or even just a muscle energy technique to adjust a pelvis, stuff like that you can really take like a really terrible pain to a sometimes level 0, like 0 out of 10. Yes. They feel great. I mean, that is so fun.
Or even just when you can just listen.
Yeah.
And take a little bit of the load they carry away from them.
For sure.
Because I feel like so many times in healthcare, our patients are rushed, even if they're not like being rushed intentionally. Healthcare just has this feeling of hurry up because the demand is so great. And I feel like as physical therapists, we have the ability to slow our body language, slow our interventions, slow our history receiving, and just really be with the patient a little bit. And I think sometimes that can be such a relief for patients, particularly in the midst of an emergency.
And when they're scared. Yeah. And Keith Roper in Utah, he does a great job of educating therapists on listening to patients. And the power of that is so much more of a healing power than what your hands can do. So yeah, I agree. And in that setting, when they're scared and they just want to be heard, then sometimes that is the most powerful thing we can do.
And I think when they know that you've heard them, the teaching that you give back is much more meaningful because they know it's the right thing, or they may not know that it's the right thing, but they know that you heard them and are using that information and reflecting it back to them for best next steps. Versus when you go somewhere and you talk to somebody for an appointment and they give you this education and you're like, yeah, like, I don't think you heard anything I said. So obviously I'm not going to do that. And I think this is kind of a gift that we have in this setting to be able to provide that to patients.
Yeah, I agree.
Anything else you want to say before we wrap up?
No, but I appreciate you spending the time with me today.
Well, thank you so much. I loved having you. And I'm going to say this forever, that direct access is nothing without early access.
Right.
I love that. Well, thank you so much. I hope
it was good to see you, Rebecca.
Take care. You too. Thanks.
Bye.